Neonatal fluid management is the precision titration of a drip rate against a pre-programmed physiological contraction of the infant's body water. Because this contraction is active from the moment of birth, the volume requirements for every patient are dictated primarily by their gestational age. In the first trimester of gestation, water makes up more than 90% of the fetus's total body weight. As the fetus matures toward 40 weeks, this volume naturally declines, reaching 78% at full term and dropping to approximately 60% by the end of the first year. We divide this total body water into two compartments: intracellular water inside the cells and extracellular water in the plasma and interstitial spaces. The overall reduction in body water as the infant matures is driven specifically by the contraction of the extracellular compartment, which drops from 60% of body weight to just 45% at term. Factoring in this programmed shedding of extracellular water is the prerequisite for calculating any neonatal fluid order. Immediately at birth, the neonate experiences an acute expansion of the extracellular compartment as the infant reabsorbs lung fluid and receives blood via placental transfusion. The primary clinical objective during the first 48 hours is to facilitate the physiological loss of this excess volume. If this diuresis is interrupted by iatrogenic fluid administration, the excess volume remains in the systemic circulation, increasing hydrostatic pressure across immature tissues. This sustained volume load is a primary driver for three major pathologies: patent ductus arteriosus, necrotizing enterocolitis, and bronchopulmonary dysplasia. These systems fail because the neonatal kidney cannot process the excess load. A mature adult kidney can concentrate urine up to 1,500 milliosmoles per kilogram to maintain balance. A full-term neonate's kidneys osmotate to a maximum of 800 milliosmoles. For a preterm infant, that capacity drops further, capping at just 600 milliosmoles per kilogram. This blunted concentrating ability leaves the patient with a narrow tolerance for fluid miscalculations, where even minor errors result in systemic failure. All very low birth weight infants transition through three distinct physiological phases in their first week, each requiring a different fluid strategy. Phase 1 is the pre-diuretic phase, lasting the first 48 hours. The glomerular filtration rate is low, and urine output is minimal. Fluids are calculated strictly for insensible water loss, with no sodium or potassium supplementation. The diuretic phase begins between days 2 and 5. As pulmonary vascular resistance drops, increased blood flow triggers the release of atrial natriuretic peptide. This triggers abrupt urine and electrolyte excretion. We adjust intake to target a 10 to 15% weight loss. By day 5, the infant enters the homeostatic phase, where urine output stabilizes. The strategy now shifts to provide a positive balance of 10 to 15 milliliters per kilogram, supporting a growth rate of 10 to 20 grams per day. Initiating the positive balance required for Phase 3 while the infant is still in Phase 1 will lead directly to sodium and potassium crises. Sodium dictates extracellular volume and serum osmolality. In the brain, these values are the primary drivers of neurological stability. If serum osmolality drops, hyponatremia, water rushes into the cells, causing neurons to swell and creating seizure risks requiring hypertonic saline. Hypernatremia reverses this. High osmolality pulls water out, causing neurons to shrivel. The brain defends by generating iatrogenic osmoles to draw water back in. These osmoles are metabolized slowly. Correcting hypernatremia too quickly will flood the neurons before they clear these osmoles, causing massive cerebral edema and central pontine myelinosis. To prevent this, the speed of sodium correction is limited to a maximum of 0.5 milliequivalents per hour. While sodium regulates the extracellular space, potassium governs the resting electrical potential of muscle cells. Because the neonatal sodium-potassium pump is relatively inactive, hyperkalemia occurs in half of all infants under 1,000 grams, directly threatening the heart. Potassium toxicity is diagnosed via EKG. We look for a depressed ST segment followed by a tented T wave. In the terminal phase, the P wave vanishes and the QRS complex widens, fusing into a fatal sine wave pattern. The immediate priority is the cessation of all potassium-containing fluids and supplements. We then initiate a pharmacological cascade: calcium gluconate to stabilize the heart, followed by bicarbonate, albuterol, and insulin to force potassium back. While sodium management requires slow, calculated neurological adjustments, potassium crises require immediate, aggressive cardiac intervention. Preventing these crises require treating fluid management as a rigid mathematical protocol. The first step is the audit of intake, output, and daily weights. In neonatology, weight change is the single most sensitive indicator of fluid status. We calculate urine output using this specific formula: the total volume in milliliters, divided by the number of hours, divided by the infant's weight in kilograms. If the result falls below 1 milliliter per kilogram per hour, the infant is classified as oliguric. The second step is factoring the environment. Premature skin lacks a competent epidermal barrier, causing insensible water loss to skyrocket through evaporation. Hardware significantly alters this loss. Radiant warmers and phototherapy increase the water requirement, while double-walled humidified incubators preserve it. A neonate's fluid requirement is never a static value. It is modified by the specific hardware they are housed in. The third step is the physical exam, where we correlate the data with the presentation of the patient. We look for skin tenting as a sign of dehydration, or edematous, shiny skin, indicating fluid overload. Volume depletion presents as dry mucous membranes and depressed fontanelles, while tense fontanelles suggest overhydration. Capillary refill is the vital indicator for peripheral perfusion. Any return exceeding 2 seconds requires immediate investigation. The final step is an audit for hidden electrolytes. The most common cause of hypernatremia in the NICU is inadvertent administration by the staff. Clinicians must audit central line maintenance, searching for hidden sodium loads in normal saline flushes, in heparin vials, and bicarbonate administrations. Because the neonatal kidney cannot compensate for bad math or careless protocols, survival depends on a strict mastery of diuresis phases and an unwavering respect for the physiological limits of the preterm infant.